Hey guys, welcome to the third podcast of Let's Revise MBBS Cardiology, and today we are going to talk about jugular venous pressure, JVP. Okay, so yesterday we saw about pulse, but why did we study pulse? What was the importance? So it gave us an idea of left ventricular function. Similarly, JVP gives us the idea about the right side of the heart, specifically the right atrium, right? And it also helps us in assessing the volume status. So in measuring JVP, we prefer internal jugular vein over external jugular vein. Why? Two main reasons. Internal jugular vein is valveless and it is straight in line with the right atrium. So whatever pressure changes are happening in the right atrium are directly transmitted to the internal jugular vein. So how do we measure JVP? We make the patient lie at 45 degrees from the horizontal. His torso lie at 45 degrees from the horizontal, and then we see the highest column of blood in the internal jugular vein. Okay, we take a scale, we place it horizontally at this top highest level of the blood column, and second scale is placed vertically at the angle of Lewis. Okay, the point where these two scales meet, we see the reading of the vertical scale, and whatever the reading is, let's consider it is 2 centimeters. So we add 5 centimeters in it and the JVP becomes 7 centimeters. Why do we add 5 centimeters? Because the center of the right atrium is 5 centimeters below the sternum. Okay, below the angle of sternum. Right. So any JVP of more than 9 centimeters or 9.5 centimeters is known as raised JVP. Okay, this 9 centimeters is from the right atrium. If we are seeing from the sternum, it will be 4 centimeters, right? So if it is above 4 centimeter, more than 4 centimeter above the sternum, then we call it abnormal JVP or raised JVP. Okay. So what is the difference between the JVP and carotid pulse? So JVP is better seen, but carotid pulse is better felt. Okay. JVP, as we will see further, has 2 peaks, but carotid pulse in carotid pulse only one peak can be appreciated. Okay, which peak? The percussion wave which we saw yesterday, that will be appreciated. Okay, now in JVP the descents are more prominent when the blood is coming, like when the now we'll see in the JVP there are A, C and V waves and X and Y descents. So X and Y descents are more prominent in JVP, whereas in carotid pulses the peaks were prominent. Okay, now and when you do abdominal compression, when you compress the abdomen with certain amount of pressure, the JVP rises, but carotid pulse does not. So those were the differences between JVP and carotid pulse, which will help us in clinical examination to differentiate both of them. Okay, so when will the JVP be raised? So since we have seen it is in direct connection with right atrium, any changes or any increase in right atrial pressure will directly reflect in JVP and the JVP will be raised. Right? So when will the right atrial pressure be increased? First, if there is resistance to flow, okay, so if the blood from the right atrium is not able to flow in the right ventricle, there is resistance. So blood will accumulate in the right atrium and the pressure will increase, and that will reflect as raised JVP. This is one condition. Other condition is the right ventricular pressure increases. So if the right ventricular pressure increases, its effect is going to fall on the right atrium. So if right ventricular pressure increases, right atrial pressure is also going to increase. Right? So in which all conditions do we see resistance to flow? Yeah, right. First is tricuspid stenosis, then tricuspid myxoma, or even constrictive pericarditis, right? And in which conditions the right ventricular pressure is increased? If the right ventricle is not contracting, the blood in the right ventricle is not going forward, then the right ventricular pressure will increase, right? So when will the right ventricle not able to contract? If there is right ventricular infarction or right ventricular failure, okay, or if there is pulmonary hypertension, then there is a bigger or a larger resistance for the right ventricle to pump against, and if there is pulmonary stenosis. So in these conditions, this is general conditions where we can see that JVP is raised. Okay. Now two important things or signs you can say. The first one is Kussmaul sign. Okay. So during inspiration, normally what should happen to JVP? Should it rise or should it fall? Right. It will fall. Why it will fall? Because during inspiration there is negative pressure in the thoracic cavity. The venous return or whatever the venous blood is coming, it is sucked in the right heart and it is eventually sucked in the lungs. So it will be pulled from the jugular vein in the ventricles, in the right side, right? So the JVP should decrease during inspiration. But if in certain cases during inspiration the JVP increases or does not fall, then it is called Kussmaul sign positive. Where can this be seen? If the right ventricle is non-compliant, if it is not able to accommodate the blood which is coming, okay, in inspiration there is more blood coming in the right heart. If the right ventricle is non-compliant, it is not able to accommodate this high volume of blood, then we can probably see Kussmaul sign positive. So right ventricle non-compliant means either the myocardium is non-compliant or the pericardium is non-compliant. In which cases is the myocardium non-compliant? If there is right ventricular infarction or restrictive cardiomyopathy, in these cases myocardium is non-compliant. It is not able to dilate as much. Okay. And in which cases the pericardium non-compliant? In constrictive pericarditis, right? So in constrictive pericarditis, the pericardium is tightly attached to the heart, is fibrosed you can say. So it is not able to dilate. So in these conditions, we see Kussmaul sign positive. Okay. The second thing is abdominojugular reflux. Okay. So it is also known as hepatojugular reflux. Here, what we do is we put the pressure on the periumbilical region for around 10 to 15 seconds and we see whether there is rise in JVP or not. In normal person, there will either be no rise in JVP or JVP will rise only for 1 to 2 seconds, but the rise will not more than 1 centimeter. Okay, this is normal. But if the patient is having impending right heart failure or any signs of right heart failure, then the JVP will increase, and this increase will be for more than 15 seconds and will be of more than 3 centimeters. So if this is the condition, if it is rising for more than 15 seconds for more than 3 centimeter rise, then it is said that the abdominojugular reflux is present. Okay, this abdominojugular reflux has very high specificity for right heart failure, for diagnosing right heart failure. Okay, even though its sensitivity is less, the specificity of this clinical examination is very high. Okay, now let's come on to the waveforms of JVP. Okay, so there are 3 positive and 3 negative waves. The positive waves are A, C and V. Negative waves are X, X prime and Y. Okay, so now let's again relate this to our cardiac cycle which we studied in our first podcast. So now let's imagine this is the time of diastole. The ventricles are in the diastole. So in the diastole we saw there are 3 phases: phase of rapid filling, slow filling and active filling. So here this is the phase of active filling. The atria are contracting and are trying to fill the rest of the 20 to 30% of blood in the right ventricle. When the atrium is contracting, the pressure in the atrium will rise and this will be reflected as the A wave in the JVP. So A wave corresponds to atrial systole, or in other terms you can say ventricular diastole. Right. Now let's skip the C wave. We'll come to C wave later. Let's move to X descent. So A wave, then there is X descent. Now after the atria has contracted, it's going to relax. Okay. So atria is relaxing, ventricle is in systole. Right. All the blood is pumped in the ventricle during the A wave. Now the ventricle is full of blood and it is contracting. But at this time atria is relaxing. So the X descent is because of atrial relaxation or atrial diastole, or you can say it happens in the phase of ventricular systole. Okay, now this was X descent. let's consider for now x and x prime descent as same. Okay, so this is x and x prime descent. Now, as the ventricular systole is coming to the end, okay, just before the S2 sound, or in the phase of, we can say, the late systole, there is venous return coming to the atrium, right? The left ventricle, or the right ventricle is pumping the blood, okay, and the venous return is coming to the right atrium during the ventricular contraction, right? So now this, and like at the end of ventricular contraction, at the start of ventricular relaxation, the right heart is getting filled with the blood. Okay, the right ventricle is getting filled with the blood. So there is venous return coming, and this venous return increases the pressure in the right atrium, right? So venous return starts in the late systole and continues till the early diastole. Okay, so the V wave is seen because of venous return. Now the last thing is the Y descent. Now whatever the venous return has come in the right atrium, it has to be emptied in the right ventricle. Okay, so as there is rise in right atrial pressure, but the right ventricular pressure is going on decreasing because the right ventricle is dilating. At one point the tricuspid valve open, and suddenly there is gushing of blood from the right atrium to the right ventricle, and there is a descent, another descent, which is the Y descent. Okay, so this was about the waveforms. Yeah, so now I have to talk about C and X prime. So during the ventricular systole, what happens is that initially the valve, okay, in the phase of isovolumetric contraction, the valve bulge in the right atrium, okay, for a short duration of time. So this bulging causes a positive pressure wave going into the right atrium and eventually in the internal jugular vein. So this causes a positive C wave, okay, only for a short duration, and then again there is a descent going on because of atrial relaxation. So therefore we divide the X descent into two parts, initial X descent and the later X prime descent, which is after the C wave. Okay, so these were the normal waveform. Now let's talk about abnormality in each of them. So let's talk about abnormality in the A wave. A wave can be prominent. When can A wave be prominent? If the right atrium is forcing the blood or is contracting against some resistance. Okay, so it has to contact with a higher pressure. At that time we will see prominent A waves. When can we see Cannon A waves? Cannon waves are very large A waves. So they can be seen when the atria is contracting against a closed tricuspid valve. Okay, there is only one way or only one path for the pressure to get transmitted, which is in the veins, in the IJV. So at that time we'll see Cannon A waves. And when will the A waves be absent? If the right atrium is not contracting, or it's not contracting adequately or effectively. Okay, so let's see example of each of them. So prominent A wave will be seen in tricuspid stenosis, okay, tricuspid valve myxoma. So here there is resistance to inflow, and in case of decreased ventricular compliance, if there is right ventricular right-sided cardiomyopathy or restrictive cardiomyopathy and right-sided infarction, right ventricular infarction. Okay, similar causes which we saw for, can you recall these causes we saw for raised JVP, right? We said that if there is increase in if there is resistance to flow, or if there is if the compliance is decreased, right? So similarly in those cases the A wave will be prominent or large. Okay, coming on to the Cannon A waves, when will the right atrium contract against a closed tricuspid valve? If there is junctional rhythm, there is a rhythm coming from the AV node and it is simultaneously firing to the atrium as well as ventricle. So both of them will contact at the same time. Okay, so here we'll see Cannon A waves, which will be regular. Okay, in complete heart block also, sometimes if the P wave and QRS complex come exactly at the same time, even then we can see Cannon A waves, right? It's not necessary that with every beat we will see Cannon A waves in complete heart block. Only if P wave corresponds with or has the same timing with the QRS complex, then we can see Cannon E waves, right? That will be irregular. Okay, and absent A wave will be seen in atrial fibrillation. Okay, now coming on to the V wave. So V wave, only one thing is important. Where do we see giant V wave or CV wave? That is seen in tricuspid regurgitation. Okay, why do we see CV wave? So because in tricuspid regurgitation, there is no time for the atria to relax, because when the atria is relaxing, at the same time ventricle is contracting. But this contracting ventricle is putting its blood in the right atrium. Okay, because there is regurgitation. So the X descent which was there because of atrial relaxation will not be there, and there will be a prominent CV wave. C will directly join to V. The X descent will be absent, right? So that is seen in tricuspid regurgitation. Now let's see about X descent. So X descent can either be prominent or can be reduced. Okay, prominent X descent. Where can we see prominent X descent? Where the atrium has to relax a lot, where atrial relaxation is the only phase where the venous return or where the filling is going to happen. Okay, this happens in cardiac tamponade, because in joint diastole, when both ventricles and atrium are dilating, there is a lot of fluid in the pericardium, and there is equalization of pressure in all four chambers. So whatever fluid or whatever venous return is going to come in the phase of atrial relaxation and ventricular systole, in this phase only. So atria has to dilate maximum. That's why the X descent will be prominent in cardiac tamponade. When will the X descent be reduced? First, if the atria cannot relax properly, or if ventricles cannot contract. So if atria are not able to relax, the conditions can be atrial fibrillation, or as we saw in the above condition, which is tricuspid regurgitation, right? In these two conditions, the X descent will be absent or reduced, and if the ventricle is not able to contract properly, which is right ventricular failure or right ventricular infarction. Okay, now coming on to the Y descent. So Y descent can either be rapid, can be slow, or can be absent. So rapid X descent means what? Rapid Y descent. Rapid Y descent happens because all the venous return which was accumulated in the right atrium suddenly goes into the right ventricle because of opening of the tricuspid valve. So this prominent Y descent is seen in constrictive pericarditis. Okay, so we will talk about this more in the constrictive pericarditis. But what happens in constrictive pericarditis is that the major filling happens during the passive filling phase. Okay, atrial contraction hardly contributes to filling of ventricle in constrictive pericarditis, but this is not the case in cardiac tamponade. In cardiac tamponade, the main thing responsible for blood going into the right ventricle is atrial contraction in cardiac tamponade, but in constrictive pericarditis is the passive filling. Okay, so in passive filling, most of the blood goes into the right ventricle in constrictive pericarditis. So rapid Y descent is seen here. This is known as Frederick's sign. Okay, and prominent Y descent or rapid Y descent will also be seen in tricuspid regurgitation. Okay, because during tricuspid regurgitation, when the ventricle was contracting, most of the blood was going into the right atrium, and when the tricuspid valve open, most of the blood is going to come down rapidly. So there will be rapid Y descent. Coming on to the slow Y descent, if there is tricuspid stenosis, okay, or myxoma, there will be obstruction to the flow from right atrium to the right ventricle. So the blood will flow very slowly. Therefore, the Y descent will be slow. And when will this Y descent be absent? So now I told you that in cardiac tamponade, the major filling is because of atrial contraction, not because of joint diastole. So in joint diastole, the pressure is equal. There is equalization of pressure. So there is no flow or hardly any flow during the diastole phase in cardiac tamponade. That's why the Y descent will be absent in cardiac tamponade. Okay, X descent was very prominent, but Y descent is absent in cardiac tamponade. Right, so that's it about JVP. I hope you liked or understood this topic. We'll meet in the tomorrow's podcast. Till then, enjoy and Keep studying. Bye bye.